Hi, thank you so much for joining us, and welcome to MLI's Community Collective, harnessing the power of the community to battle obesity. This is the first of a three-part series talking about the importance of starting a conversation with your patient about an obesity diagnosis. Part 2 will be another virtual activity just like this, but next week, Tuesday, May 14th, and that'll look at some of the new and emerging data on anti-obesity medicine. Now, in the third week, we'll all meet together for a live in-person event at Belga Cafe, the Betsy, the rooftop gin garden, in our beautiful downtown Washington, D.C., on Tuesday, May 21st. Our hope is that after listening to both these virtual presentations, you'll come with your questions on challenging cases, and don't worry, you don't have to write anything down. But really, this is an exclusive event for you to meet your colleagues and talk about obesity so that you feel comfortable making a difference in the lives of your patients who face the challenges and comorbidities that may come with this diagnosis. And don't worry if your colleagues weren't able to join tonight. This information will be available to them at their convenience, and we'll put that link in the chat for you so that they can view it prior to us being online. So tell your friends and make it a date. Now, before we start, let's warm up with a couple of pre-test questions. Please answer on the pop-up on your screen. Pre-test question number 1. Among the following comorbidities, which has the greatest rate of co-occurrence with obesity? Pre-test question number 2. Your 44-year-old patient with a BMI of 36 presents to the clinic for an annual visit. She has a history of hypertension. What % weight loss is needed to see a therapeutic benefit in her hypertension? And pre-test question number 3. Which of the following is most accurate regarding semaglutide and tirzepatide? Okay, so we will be monitoring the chat. Please feel free to ask your questions there. And I want to thank everyone who is joining us on YouTube. So with all that said, it is my great pleasure to introduce one of the leading experts in obesity medicine, Dr. Scott Kahan, the director of the National Center for Weight and Wellness. Dr. Kahan, thank you so much for joining us, and I'd like to turn this activity over to you.
Thanks very much, Kristen. I'm just going to share my screen here. Give me a moment. There we go. Okay, and you should all be able to see my screen here, and let's dive right into it. So here are the key learning objectives we're going to cover. We're going to talk about risk factors and common medical consequences of obesity. We'll talk about obesity diagnosis. We'll talk about appropriately discussing effective weight loss options, including pharmacotherapies and using shared decision-making approaches. And we'll talk about evaluating the safety and efficacy of the most recently approved and emerging anti-obesity medications. We'll start with that tonight, although next week we're going to focus more exclusively on the anti-obesity medications. So with that said, here is one of the more important slides that I'm gonna show you. Now, we all know that obesity is rising in prevalence and has been for a long time. And we all know that obesity is associated with a range of health problems, but most people don't appreciate just how many and how significant the extent of health problems are that are linked to obesity. There's actually more than 200 different conditions linked to obesity. These are some of the more notable ones, and they affect every organ system of the body, and more than you can possibly imagine in terms of the common medical conditions that we see. Several are particularly strongly linked with obesity. For example, about 75% of people with hypertension have obesity. About 50 to 75% of people with non-alcoholic fatty liver disease have hypertension. More than 80%, and in some populations, more than 90% of patients with type 2 diabetes have obesity. And you can see the rest of these here. Whoops. There we go. And you can see a number of other comorbidities here. These are among the comorbidities that are most strongly linked to obesity. Particularly notable is type 2 diabetes. So depending on the study we look at, depending on the year, the data is slightly different, but big picture, virtually everyone, 80% or more often of people who have type 2 diabetes have a BMI greater than 30. So it's diabetes in particular is such a closely linked condition to obesity. It's something that if we treat the obesity, typically we can either significantly improve the diabetes or potentially entirely resolve it, and in many cases, prevent it entirely from happening. So that gets actually to one of the pretest questions that we did. Here's that same question. Among the following comorbidities, which has the greatest rate of obesity co-occurrence? And so you can see the potential answers here: the non-alcoholic fatty liver, obstructive sleep apnea, hypertension, and type 2 diabetes. The same one that you answered before. Interestingly, in the pretest question, the results were all over. Several people said hypertension, several said obstructive sleep apnea. Of course, the key answer is type 2 diabetes here. All of these are linked to obesity, but type 2 diabetes is particularly strongly linked with obesity. So let's move on here. Now, we know that obesity increases the risk of all these conditions. We also have really good data now showing that even relatively small amounts of weight loss can significantly improve many of these health conditions. Most notable are the diabetes, hypertension, and dyslipidemia. So as little as 3% body weight loss starts to prevent diabetes and starts to improve glycemic control. With hypertension, once you get to about 5% weight loss, we start to see improvements in blood pressure, and that continues to increase even beyond 15%. So, there's sort of two messages on this slide. One is relatively small amounts of weight loss typically improve a range of health conditions, including diabetes, including hypertension, including dyslipidemia, sleep apnea, fatty liver, and others, as you can see here. But the other really important point of this slide is that, in general, done appropriately and reasonably, more weight loss usually leads to even more improvements in these health conditions, which then gets to another one of the pretest questions. So a 44-year-old patient with a BMI of 36 presents to the clinic for an annual visit. She has a history of hypertension. What percent weight loss is needed to see a therapeutic benefit in her hypertension? So let's see again now what you all think about this. And everyone is right on target here. So once you get to about 5% weight loss, you start to see improvements in blood pressure, and the improvements mount with more weight loss. Even beyond 15%, you keep getting more and more improvements in blood pressure, typically, on average at least. So very nice there. And we'll keep going here. So BMI, of course, we have to use this in our clinic. It gives us some important information for the patient in front of us. And it's also, of course, used for all sorts of policy-related reasons, including eligibility for treatment options for obesity and such. On a population level, BMI is a very good measure We know clearly that on average, in a population, as BMIs go up, body fat percentages go up on average, and health risks go up on average. The problem is that on an individual level, there's a lot of error in the BMI measurement. So for some people, as BMI goes up, percentage body fat goes up and health risks go up. But for other people, it's not as clear. And so while we need to use BMI as the first step in evaluating weight and overweight, while we need to document it in charts, while it's important for all sorts of reporting, it's only going to be a part of how we work up patients. BMI doesn't take into account a number of really important things. For one, doesn't take into account body composition, whether someone has a lot of fat or a lot of muscle or a lot of bone, all shows up the same on BMI. While it's correlated again on a population level with body fat percentage, on an individual level, there's a lot of error there. So some people with high percentage body fats have relatively low BMIs, particularly people who are frail. And some people who are very muscular can have a relatively low body fat percentage and yet a high BMI. So there's some categorization there. BMI also doesn't tell us how healthy someone eats or whether they exercise or not. It gives us no insight into genetics or race or other risk factors and so forth. So important, we need to document BMI, but it's not good enough by itself. Now, there's a range of other measures that we can use, but one of the most important is waist circumference. So one of the things we know about waist circumference is whereas BMI itself is fraught with error in terms of its correlation with long-term health risks, waist circumference is pretty clearly linked with long-term health risks. So as waist circumference increases, it's very clear that all-cause mortality and other long-term adverse health risks increase as well, both in men and women, whether smokers, non-smokers, etc. So a very clear link here. And that's one of the reasons that waist circumference is a particularly valuable and still relatively easy measure to use in the clinic. It's not as easy as just calculating a BMI, of course. We have to do some extra work to get it, but it's relatively straightforward. And it's something that as physicians, we don't necessarily need to do. Our nurses or our MAs can do that measurement once we train them appropriately. And then we can have that information and it will inform our risk benefit stratification process. So when we pull together both BMI and waist circumference, we get a lot more information for classification. So here on the left, you see BMI. As BMI goes up, the obesity class goes up, of course. But again, it's not ideally linked with health risk. When we add in waist circumference, that gives us more information. So here in this middle column, that's men and women that have a relatively lower waist circumference. Yes, as their BMI goes up and as their BMI goes up, despite a relatively low waist circumference, their health risk goes up, but at a much lower rate compared to men and women that have a high waist circumference. For them, particularly when they have a high BMI and a high waist circumference, there's a much higher risk of long-term health risks and adverse health conditions, including increased risk, again, of mortality. So we really want to evaluate waist circumference in our patients. Again, we can train our assistants or nurses to do this, but we want to make sure that they do it right because, unfortunately, the waist circumference measurement is often done poorly, and then we don't have great data. So here's how we want to do it. Locate the upper hip bone and the top of the right iliac crest. Place the measuring tape in the horizontal plane around the abdomen at the iliac crest. Assure the tape is snug but doesn't compress the skin. The tape should be parallel to the floor and record the measurement at the end of a normal expiration. And just because this is often done poorly in clinics, I just want to kind of hit this home a little bit. So let me show you a quick video where we get an expert explanation of this. So here we go.
For patients with a BMI greater than 25 but less than 35, measuring waist circumference can provide additional information about the patient's risk of complications from obesity. The first step is to ensure that the patient is in a private location, such as an exam room, and ask for permission to take a waist circumference.
Your waist circumference can be an important indicator of your health. Is it okay if I take a quick measurement of your waist circumference?
With the patient's permission, ask them to stand up in front of you and have them lift their shirt out of the way to visualize the top of the iliac crest. Have the patient locate the top of their iliac crest and verify the location by palpating. Place one end of a tape measure just above the top of the iliac crest. Have the patient hold this end of the tape measure in place. While you hold the slack of the tape measure, ask the patient to slowly make a 360-degree turn. Once they have turned 360 degrees, ask them to release the tape to you and relax their arms at their side. Ensure that the tape measure is parallel to the ground. The tape measure should be snug but should not compress the skin. Ask the patient to take a deep breath and exhale. Take the measurement at the end of the exhalation.
Okay, so again, just because it's so important, we wanted to hit that home. And so now let's move on to additional evaluations that we want to get from patients. So here's a bit of a case study, and we'll get back to this engineered patient example a few times throughout the rest of our talk tonight. So this is MS. She has a weight of just under 200 pounds. She's 5'2". Her waist circumference is 41.5 inches. So that's in the high waist circumference category. Her BMI is 36. She's already got a borderline high blood pressure, 130/80. She's got a borderline high heart rate, 90 beats per minute. Cardiac exam was normal. And then here's what we see on the blood test results. So her glucose was 110, A1C 5.9, 200 on the total cholesterol, 112 on the LDL, 50 on the HDL, triglycerides 148, and you see the eGFR there. And so importantly, for several years, her cholesterol and blood glucose in particular have been rising. So this is a pretty typical patient we see in the clinic. You know, she's got excess weight that's been increasing for years. She has a high waist circumference, and now even though she's she's not in dire circumstances right now in terms of her health. Her cholesterol has been increasing, her blood sugar has been increasing, and we can extrapolate that if she continues on this path, that she's probably going to have frank hypertension within just a few years. She's going to be a whole lot closer to diabetes, if not in the diabetes range, within a few years. Her cholesterol will continue to elevate, and all of these things, as we talked about earlier, are linked to obesity. So this is a great patient to try to be proactive on, start discussing obesity, start discussing her weight, and hopefully, if we can help her address the weight, we can improve all of these conditions and perhaps others that we're not even highlighting here. So importantly, starting the discussion around obesity sometimes can be challenging. A lot of times, patients are very sensitive about their weight and their appearance, understandably. A lot of times as physicians, it can be a little intimidating to bring it up. And sometimes if we don't do it in the right way, it can be off-putting to patients, and sometimes they don't come back to see us. So there's a few really, really basic strategies that can help a lot. And one is using neutral and thoughtful terms to discuss obesity. So nobody likes to be called obese, let alone morbidly so. Right off the bat, that it's not a motivating term, and it's often a term that feels stigmatizing or blaming. And so one of the things that a number of studies have shown over the years is that if we use more neutral terms, that tends to be more motivating for patients, and it tends to bring patients in rather than sort of create a wall between us and the patients. And so some of the more neutral and more motivating terms that I would suggest using is just weight or unhealthy weight or high BMI, or perhaps a weight problem, again, instead of calling someone obese or fat, of course, let alone morbidly obese or the like. This is such a simple thing. It takes no energy on our part. It takes no time on our part, but can make a big difference in terms of the relationship that we build with patients and in terms of patients' willingness to talk to us about obesity and work with us on it. So I would strongly recommend remembering this and using terms like this in the clinic. Another small thing in terms of terminology is using person-first language. This is something that is commonplace in other areas of medicine. So we don't call patients diabetics. We say that they have diabetes. We don't call patients cancerous. We say that they have cancer. We don't call patients depressives. We say that they have depression. And similarly, we shouldn't call patients obese. We should say that they have obesity. On the one hand, again, as I just mentioned earlier, nobody likes to be called obese. So for that reason alone, this is a useful strategy. But on top of that, it focuses the attention on the person, not the disease. Okay, so using person-first language is really appropriate. And by the way, for those of you that are researchers in the obesity journals, in Journal of the American Medical Association, and most other highly rated journals, this is what's recommended in terms of the terminology to be used in research publications. So this goes even beyond the clinic, but it's particularly important in the clinic because, again, the words that we use matter with patients. It's important in particular for us to be aware of our own unconscious biases just by living in the US and most of the Western world where weight and appearance is often stigmatized. We all have our own biases, often unconscious and below the level of our consciousness in terms of what we think about people who are heavier and such, and that can play out in the clinic as well. So there are some things that I think it's really important for us to be aware of and some strategies in terms of speaking with patients. So for one, we want to use non-judgmental terminology. We want to give feedback that is non-judgmental and thoughtful and neutral to patients. We want to recognize ourselves that obesity has many factors and some of them are outside the person's control. So of course, what people eat is important in terms of their weight. And of course, how much people exercise is important in terms of their weight, but that's not it alone. Genetics are important. Lifestyle outside of our control is important. And so if we don't consider that, then we often go into patient interactions sort of blaming them and just assuming that it's all their fault that they can't manage their weights. We want to discuss and identify achievable, sustainable goals rather than just saying you need to eat less and exercise more and lose all the weight to get thin and then your health will be improved. That's not helpful for anyone. We want to explore all causes of the patient's presenting problems and the patient's weight. Again, to go beyond just simply what they eat and how much they exercise. And some of that we'll talk about during tonight and the next two sessions. We want to recognize that many patients have tried over and over and over again to lose weight. So this is a pitfall that many doctors fall into. You see someone that's heavy and you assume that no one's ever talked to them about their weight or they never tried to lose weight. And then when you bring it up with them, with that assumption, it can often be very off-putting to them because studies show that most people that are heavy, particularly people who are very heavy and who have severe obesity, they have tried repeatedly to lose weight. And so making assumptions that they don't know that they're heavy or that they haven't tried to lose weight is often very off-putting to them. And we should consider that patients may have previously experienced weight bias from other healthcare providers. So again, we should be thoughtful and supportive and non-judgmental when talking to our patients about weight. It's also valuable to reframe the conversation around obesity. So for one, ask permission before talking to patients about weight. It can be as simple as saying, I've noticed that your weight has been increasing over the past few years. Would it be okay if we talked about this? Because weight often underlies a lot of health problems, and we can work together to address the weight, and I can help you in terms of coming up with good strategies. Things like that. It's a helpful way to give the power to the patient so that they feel comfortable talking about this. And it's also a helpful way for us, because it can be uncomfortable to bring up weight and obesity with patients. It's a non-judgmental way to break the ice with patients. Again, we want to use person-first language. We want to use evidence-based information. So rather than saying something like, if you don't lose weight, you'll get diabetes, instead we want to say that obesity is linked with all sorts of health conditions. You can give them some specific percentages if you like, if you think that will be helpful. Often patients are very responsive to that. And then we want to be empathic, and we want to be understanding of patients, and we want to work with patients collaboratively. So rather than just saying, like, you need to eat less and exercise more, or don't you want to lose weight and be a normal weight, instead we want to ask them guiding questions to better understand what has led to their weight gain, how that affects their lives, and how we might be able to help them to manage the weight. So here are some considerations for shared decision-making. We want to ask thoughtful, non-judgmental questions, clarify the information as you go through, and repeat back what the patient said to make sure that we fully understand what they're saying and we don't misunderstand anything. And also because that can continue to guide the conversation. Don't interrupt patients, of course. We want to assess their motivation and confidence with the lifestyle changes that we might be talking about. Communicate your intention to help, offer your help, being available to them, and offer your relationship and your shared relationship in this. Acknowledge their emotions and feelings around their weight and around the process of weight management. Collaborate with them to identify what goals they want to have and what the specific next steps in management might be. Use weight neutral terms, and give good, positive, reinforcing guidance and reinforcement, and instill confidence in patients. And then in terms of education and counseling, make sure that you understand the patients, ask thoughtful questions, make sure you're on the same page, discuss specific goals and specific steps to take, elicit and address barriers to change, and explain the nature of obesity and how small steps may significantly improve their health. And this gets to something that we all learned in medical school, but often we forget about it in clinical practice, and that is the SMART goals and SMART decision-making processes. So that stands for being specific. So what are the goals, and who, and how to go about them? We want to make measurable goals. So what are we aiming for? By how much? In what specific time course, and so forth. We want to make sure that the goals are achievable, and how to get from here to there. We want to make sure that these are relevant goals for patients. We don't want to be telling the patients what their goals should be. We want to make sure that together we are making the goals so that they can decide on what's relevant and important to them. And again, time-bound SMART goals. So for example, these are generic but common examples of specific behavior change goals. So that together, you and the patient might decide that she wants to use a healthy, portion-controlled frozen meal that gives a reasonable amount of protein and grains and vegetables, and that makes it easy to eat healthy for lunch rather than going out to eat in a restaurant, let alone a fast food meal. And I would add to that maybe how many times a week she wants to do that. So it may not be realistic to have a frozen meal every day of the week, but maybe if she goes from none to 3 days a week, that might be particularly achievable and, of course, relevant. Another specific goal may be walking 5 to 10 minutes per day during her lunch break. And what's really important on that example is the achievable part of it. 5 to 10 minutes a day at lunch might not seem like a lot. But if this person is not doing anything, even though ultimately we want to build up to more activity than that, if she's not doing anything, 5 to 10 minutes per day on the one hand is going to be valuable, and on the other hand, just feels more achievable rather than saying out of nowhere she has to go from no activity to an hour of exercise a day. So keep that in mind. And then another example of a specific behavior change goal, maybe adding 2 fruits and 3 vegetables most days of the week, or 5 days a week. So these are just some examples. They're going to differ from person to person. But again, the SMART goals the SMART goal process that we learned in medical school, we often forget about it, but it's one of the oldest strategies in the book around health behavior changes, and it continues to be very well studied and evidence-based and very helpful clinically. So let's say you go through all that and she makes these goals and starts to put them into place, and you see her 3 months later. She's lost a few pounds, but it hasn't gone all that far. She's pretty disappointed with her progress. What do you do then? On the one hand, you can give her positive reinforcement and feedback that, in fact, she's made some really positive changes. She lost 5 pounds. That's not nothing. Given her starting body weight, 5 pounds is already getting close to that 3% body weight loss that we learned earlier is associated with improvements in glycemic control and improvements in triglycerides. And it's getting close to where we would see improvements in blood pressure and so forth. So reinforcing that and potentially having her identify some additional behavioral changes that feel achievable for her, that may be the next step. And then you see her a few months later, see how it goes. If she lost another 5 pounds at that point, then all of a sudden now she's at 10 pounds. That's getting close to 5% weight loss, and maybe you go from there. On the other hand, this may not be enough. She may be heavy enough that just a few pounds is not going to make enough of a difference. She may be so disappointed and dejected in that relatively slow process that she's ready to give up. And on top of that, even though she may have made some nice health improvements, some nice behavioral change improvements, and the weight is down, we have very good data showing that when people start to lose weight, often our bodies fight back and the weight starts to go back up. And there's a few reasons for that. For one, as people lose weight, notably once they get to about 10% body weight loss, their resting metabolic rate decreases by 10 to 15% or sometimes more. And so they end up burning fewer calories, which counters then the hard work that they're doing and the weight loss that they do. Moreover, once people lose about 10% of their body weight, hunger hormones tend to go up, which tends to increase the risk for eating more and regaining weight. So for all these reasons, this may be when we consider escalating care to the use of medications for weight management. There's a whole lot more we can talk about in terms of behavioral change and non-medication treatment. That's outside the scope of what we're going to cover in these few weeks that we have here. But this may be, again, when we escalate to the use of pharmacotherapy. So we've had a number of very good medications for obesity treatment for the past 2 decades or so, phentermine even longer than that. But they lead to relatively modest weight loss. For some people, very effective, and that's all you need. For other people, they don't lead to enough weight loss. But let's just look at them briefly. So phentermine was approved way back in 1959. It's approved for short-term use, which is up to 12 weeks. We can use it off-label beyond that, but typically people tend to build a tolerance to it. And so it's usually not very helpful beyond a few weeks or a few months. It's a sympathomimetic amine that leads to a decrease in appetite. The very low doses of phentermine can be used up to 3 times a day, although the doses that most people use, which is the 37 milligram dose, that can only be used once a day, and even that is a relatively high dose. And the 1-year weight loss with this is only 3 to 7% weight loss, which usually happens pretty quickly, but then it stops working in most people because they build a tolerance to it. Then we have orlistat that was approved in the late 1990s. That is not only approved as a prescription medication, but it's such a safe medication that it was actually approved for over-the-counter use as Ally. That was the first of the medications that was approved by the FDA for long-term use. And all of the medicines since then have been approved for long-term use. This is a pancreatic lipase inhibitor, so it blocks about 30% of the fat that people eat at meals when they take the orlistat. It's typically used TID with meals. And again, it's a relatively modest weight loss that we see with this medication, 3 to 8% or so. Then beginning in 2012, we have the more modern obesity medications that were approved. In 2012, Qsymia or phentermine topiramate extended release was approved, again approved for long-term weight management. That includes phentermine, but it also includes topiramate, which is an old anticonvulsant and migraine prevention medication. It has a number of effects, including carbonic anhydrase inhibition. It has some GABAergic effects. We have no idea how it leads to weight loss, but we know that it does lead to weight loss, particularly in combination with phentermine. And so this medication, the combination of phentermine and topiramate, is approved for long-term use. It decreases appetite. It's used once daily, and it leads to very good weight loss for most people, up to 15% or so weight loss. So very helpful medication for many people. Then we have naltrexone bupropion extended release, or Contrave, that was approved in 2014, also approved for long-term use. Naltrexone is an opioid receptor antagonist. Bupropion is a dopamine and norepinephrine reuptake inhibitor. By themselves, they don't lead to weight loss. In combination, they decrease appetite, often decrease cravings as well, and lead to weight loss. This is taken twice daily, and it leads to an average weight loss at 1 year between 8 and 12%. And then we have the first of the GLP-1 medications that was approved. This was approved in late 2014, also for chronic obesity management. That's Saxenda or liraglutide. It decreases appetite. This is a subcutaneous injection. It's done once daily, and it leads to a nice but still modest 7 to 11 or so percent weight loss. So these are all meaningful and useful medications for many people, but for others, just not going to be effective enough. But let's keep talking about these. So here are some adverse events and drug-drug interactions that can occur. The most notable ones with phentermine is insomnia, headache. Fatigue is actually not common unless it's bothering your sleep, and then secondarily, it can cause fatigue. Palpitations will sometimes occur. There are some serious adverse events that occur. They're not common at all when this is used appropriately, but you need to be mindful of these. Orlistat typically is quite well tolerated, but for many people, there can be a lot of gastrointestinal side effects, flatulence, fecal urgency, and such. And then you can have decreased absorption of some medications, and it can leach some fat-soluble vitamins. So it's recommended to take a multivitamin separated from the time of the orlistat administration. With Qsymia, tends to be very well tolerated, but you can get constipation, sometimes paresthesias, sometimes dry mouth, and then again, some serious potential side effects here. These are incredibly rare. I don't know that I've ever even seen these side effects, and I use this medication very frequently, but they can happen, so you need to be mindful of them. With naltrexone bupropion, again, a number of potential side effects. The most common one with this one is nausea and sleep difficulty. Again, there are some serious side effects that are very uncommon but can occur. And then you see the contraindications there and the drug-drug interactions. And then with liraglutide, most common side effect by far is nausea, followed by a range of gastrointestinal side effects. There are, again, some serious side effects, the most notable being pancreatitis. It doesn't happen often, but it does happen, so we need to be mindful of that. Most cases of pancreatitis are due to gallbladder disease, and gallbladder disease typically happens from quick weight loss, so you need to be very careful with that. GLP-1 medications, all of them can raise heart rate because there are GLP-1 receptors on the sinoatrial node of the heart, so we need to be mindful of that. These risks are not common, again, but we need to be attentive to those, okay? So these are what we often call the first generation anti-obesity medications. And then just in the last few years, we have, in the last 3 years or so, we have what are often called the second generation medications that have now been approved for obesity. So you see at the bottom here, Wegovy or high-dose semaglutide, and then Zepbound or tirzepatide, both of which previously were approved for diabetes management and now are also approved for obesity. Wegovy or semaglutide is a GLP-1 receptor agonist that tends to lower appetite and also increase the feeling of fullness. It's a subcutaneous injection that's done once weekly. So this is the first of the weekly injections for weight loss. And the average weight loss is a little bit higher than what we see with the first generation medications, 10 to 18% or so with high dose semaglutide. And then the most recent medication for obesity is tirzepatide or Zepbound, as it's known for obesity management. Again, that's approved for chronic obesity management. Now, this one has both effects of GLP-1 agonism and also GIP agonism. And that dual agonism of both of these gastrointestinal peptides leads to better improvements in appetite and fullness and more weight loss compared with semaglutide and compared with the first generation medications. Here we typically see on the order of 16 to 22% weight loss with tirzepatide. And again, it's also a once weekly subcutaneous injection. So we have some very good medications. Again, going back 2 decades, we've had good medications, but the newer ones are even better. And we're going to talk a whole lot more about them in next week's session. And then the week after, we'll have lots of time to talk as well about them. And that then gets to the third question that you all answered in the pretest. So which of the following is most accurate regarding semaglutide and tirzepatide, the second generation obesity medications? So let's see what you think on this one. So in the pretest, the answers were all over the place, but now everybody got the right answer in the post-test. So the high-dose semaglutide and tirzepatide, the second generation anti-obesity medications, lead to more than 15% weight loss in over half of patients with obesity when used as an adjuvant to lifestyle modifications. And that's important here, and people don't often realize this. None of these medications, not the first generation, not the second generation, automatically or magically lead to weight loss. They all can help with weight loss by helping modulate appetite or fullness, so that if patients are working on managing what they eat and exercise, these medications can help improve the weight loss. That's particularly important because so many patients don't realize that. And often they think if they take this medication, it'll just automatically lead to weight loss and solve all their problems. And that just sets them up, unfortunately, for, at best, unrealistic expectations. And often it sets them up for failure. So we want to be mindful about that. And we want to guide patients in that. So that's the last part of our session for today. I wanted to give you a background in how to talk about obesity, how to evaluate for obesity, and to begin thinking about medications. We're going to spend the whole next session next week on medications, and then we'll have more time still in 2 weeks in person to talk more about that. So let me stop sharing here. We do have time for some questions if anybody has on their minds. And if not, we can, of course, move on, and you can take back the rest of your time. But is there any questions that anyone has? And again, we're going to have next week and then 2 weeks from now in person, where we can talk more and more, and any questions that come up, you can bring up then. But let me just see one more time. If there's any questions that come up, you can put it in the chat, or I think there's a way of raising your hand if you'd like. Maybe just a few more seconds if there's any. Okay, then thank you everyone for your time, and I look forward to talking more next week. To claim your CME credits, you can scan the code here or visit the link that's on your monitor. So thanks everyone.
Thank you, Dr. Kahan, for this wonderful discussion. As he mentioned, please scan this if you need CME credit. I'd like to thank you all for joining us again and look forward to next Tuesday's discussion. Thank you.